Assalamu alaikum class. Today we study about biomechanics of elbow joint. Structure of the elbow joint. Elbow is generally considered a simple hinge joint which has three articulations: humeral joint, humeroradial joint, and proximal radioulnar joint. These bony structures provide about half of the elbow's stability, while the remaining stability is provided by the joint capsule and the ligament. Which are these? Lateral, radial collateral ligament, medial ulnar collateral ligament, and annular ligament. These are articulations. Humeral-ulnar joint is a true elbow joint. It provides strong bony configuration. It is a hinge joint in which the humeral trochlea articulates with the trochlear fossa of the ulna. It allows flexion and extension movement, while in some individuals, a small amount of hyperextension is also allowed. Humeroradial joints are the gliding joints in which the capitulum of the humerus articulates with the proximal end of the radius. It is a modified ball and socket joint. Proximal radioulnar joint is the pivot joint with forearm pronation and supination occurring as the radius rolls medially and laterally over the ulna. It has annular ligament which binds the head of the radius to the radial notch of the ulna and forming the proximal radioulnar joint. It allows supination and pronation movement. Medial ulnar collateral ligament has two bands, anterior band and the posterior band. Anterior band are the primary stabilizer against valgus forces and prevent from the elbow injuries. It has further three bands. First is anterior to medial epicondyle, second is below tip of the medial epicondyle, and third is inferior edge of the medial epicondyle, while the posterior band limits the elbow extension. Lateral radial collateral ligament is a fan-shaped ligament which resists from various forces and prevent from further elbow dislocation or elbow injuries. Annular ligament which form proximal radioulnar joint. Carrying angle. The angle between the longitudinal axis of the humerus and the ulna when the arm is in anatomical position is referred to as the carrying angle. The size of the carrying angle ranges from 10 to 15 degrees in adults and tends to be larger in females than in males. Why it is larger in females than in male? Because of the secondary sexual characteristics. It changes with the skeleton growth and always greater on the side of dominant hand. Why it is important to measure the carrying angle? It is because when evaluating elbow injuries or disorders, it requires for reconstructional surgeries of the elbow joint and for arthroplasties. These are the bones. Movements at the elbow joint. In flexion extension, the muscle which crosses anterior side of the elbow are the flexors, which includes brachialis, bicep brachii, and the brachioradialis muscle. While the muscles crossing posterior side of the elbow are the extensors muscles, which include tricep and conus muscle. These are pictures of flexor and extensor muscles. In pronation and supination of the forearm, which involves rotation of the radius around ulna, it has three articulations: proximal and distal radioulnar joint and middle radioulnar joint. Proximal and distal radioulnar joint both are pivot joint, while the middle radioulnar joint is a syndesmosis joint. Pronation is facilitated by the pronator quadrator muscles, while the supination is by the supinator muscle. These are muscles. Loads on the elbow joint. Large loads generated by the muscles that cross elbow during the forceful pitching, throwing, also in weightlifting and gymnastic muscles. Although the elbow is not considered to be a weight-bearing joint, it regularly sustains large loads during daily activities. Extensor movement arm shorter than the flexor movement arm because the tricep attachment to ulna closer to elbow joint and center than those of the brachialis on the ulna on bicep on radius. This means that the elbow extensors must generate more force than the elbow flexors to produce the same amount of joint torque. This translates the large compression forces at the elbow during extension than during flexion when the movements of the comparable speed and force requirement are executed. Movement arm also varies with the position of the joint. Common injuries to elbow: sprain. Enforced hyperextension of the elbow, coronoid process of the ulnar displays posteriorly on the trochlea of the humerus. Such displacement stretches the ulnar collateral ligament, which may rupture anteriorly and cause sprain. Dislocation mostly occur fall on outstretched hand and due to forceful twisting blow. In nursemaid elbow or pulled elbow, this injury is mostly occur in young children aged between 1 to 3 years. Allows adults should avoid lifting or swinging young children by the hand, wrist or forearm, as this type of injury can result. Epicondylitis is the inflammation and microrupturing of the collagenous tissues on either the lateral or medial side of the distal humerus. It has further divided into lateral epicondylitis and medial epicondylitis. Lateral epicondylitis is also called tennis elbow. The amount of force to which the lateral aspect of the elbow is subjected during tennis play increases with the poor technique or improper equipment. It is mostly occur in tennis players, swimming, and in fencing. Medial epicondylitis, which is also called little leaguer elbow, is the same type of injury to the tissues on the medial aspect of the distal humerus. It is mostly common in pitching or throwing. Elbow injuries are more chronic than the acute injuries. Next is valgus instability, in which damage of the ulnar collateral ligament occur mostly in throwing. These are imagery presentation of the deformities: little leaguer elbow, which is called medial epicondylitis; pulled elbow, which is also called nursemaid elbow. It is occur due to lifting or swinging young children by the hand, wrist or forearm, which causes partially slipped radius or torn the ligament. Lateral epicondylitis and medial epicondylitis. Valgus or varus deformity. Thank you.